Welcome to Business Authority Radio, bringing you insights from today's thought leaders, professionals, and influencers. With your hosts, Neil Howe and Craig Williams.
Hello and welcome to the show. This is your host, Neil Howe, and we are here with Dr. Jim Ruetenik. He helps people whose lifestyle is limited by pain and helps them return to being active, social, and not focused on their limitations. He is a doctor of physical therapy and has been practicing physical therapy for over 20 years. Welcome to the show, Dr. Jim.
Thanks very much, Neil. Happy to be here.
Well, let's get right into it. You know, we've been talking to a few different physical therapists in October, which is National Physical Therapy Month. And, you know, they each have a different definition of what physical therapy is. So describe to me what physical therapy is to you.
Physical therapy is the process of making a person move better. So figuring out what's limiting them from being able to move in a way that will fulfill their life and allow them to carry out their life, and then addressing that. For us in this outpatient orthopedic setting, it's almost always pain, but for some people it can be a balance issue or a strength issue or confidence, but pain is what we're addressing, and that's the main limitation people are having to fulfilling their life.
So really, you're the movement experts. You focus on how the body moves biomechanically, and you correct those issues that people are having that are causing pain within their body because of incorrect movement. Is that correct?
That's correct. That's exactly correct. Yeah, if we move in the way that we're designed to move, we won't have pain. Even if we have things like meniscal tears or knee arthritis or disc herniations, if we can take stress off of those areas by restoring or getting closer to the way that we're designed to move, then the pain will subside and go away.
So what are some of the challenges that people have? Obviously, there's a range of patients that you see from, you know, the young, active sports people that have injuries all the way up to the elderly who are just having difficulties moving properly. What challenges do they have that are causing them to have these pains in the first place?
I've come to the realization it's the big picture is that we're not moving enough. Before 1950, back pain barely existed. Right now, 1 out of 6 Americans is in chronic pain, and it's almost all back pain. So what's happened since 1950? Well, I think it started with cars, which allowed for suburbs. And now people are sitting, and then it went on to TVs and screens and then jobs that involve sitting. So we're basically sitting all day long. We're designed to be moving and active, and our body, our body just didn't evolve to do what we're doing right now. So it's led to significant weakness and joints tightening and muscles tightening and posture changing. And then that changes the way that we lift our arm, or it changes the mechanics in the shoulder joint, changes the stresses in the low back, changes the way that the forces are going through the knee. And then those things lead to pain. So what we try to do is address as many of the small mechanical faults or issues or patterns or limitations, and that then restores, gets a person closer to normal motion. they end up feeling freer and moving easier, more efficiently. But it also allows the pain to subside.
We do live a very sedentary lifestyle now. I know growing up for myself in Scotland, everything was designed, and it's the same in much of Europe too. Everything is designed that you walk everywhere. People don't necessarily own cars. You think about the Netherlands, where people are biking everywhere. Why wasn't the United States designed in the same manner?
Yeah, I mean, that gets to a bigger picture. I mean, part of it is the size of our country, and weather variations and efficiency and things like that. But I think in the long run, it's really something we have to reconsider is the city model and of being able to walk to the store or to work, and changing our work environments so that we're more active. I've heard of examples of using treadmills during meetings. It keeps people moving. It makes them more creative. And it keeps the meetings short and to the point. Some people are using walking treadmills at work or standing at work. And studies show that really what we need is a variety of movement, a variety of positions. Standing in one place all day isn't good, and sitting all day isn't good. But getting up and down every 10 or 15 minutes and walking to a printer that's maybe down the hall, drinking a lot of water so that we have to get up and go to the bathroom, or just figuring out ways to continue to keep us moving a little bit. One book I read said the ideal pattern of movement for us is the puttering grandmother, or the model of the puttering grandmother, just kind of going around and doing light things all day long that keep things moving.
Yeah, so it really is about movement. I know the recommended exercise is for 30 minutes of exercise 3 times a week, but that really isn't enough to compensate for sitting 8 to 10 hours a day at a job, is it?
No, and I think those guidelines have come about from the idea of cardiovascular fitness and preventing cardiac disease, and it's really not an orthopedic approach or prescription based on what's best for our bodies orthopedically. It's more based on what's best for us in terms of cardiovascular. So I think it really has to be rethought. And there's an expression now that sitting is the new smoking. I think those types of things will get people's attention. I think we have an idea in our head of the damage that smoking does, and we need to start relating that to sitting as well. If you look at a primitive culture, for example, they don't have chairs. They're either standing or sitting on the ground, and moving all day long. And that's really what we're designed for.
And they don't have the same problems as we do as far as pain and pain management either.
Yeah, I had an amazing experience this summer. I was in Guatemala at a rural agricultural village and talked to the health coordinator and asked him about pain. And he said pain isn't an issue. They don't really have much back pain. They don't have the plantar fasciitis and bicipital tendonitis and all the other itises that we have, but yet they don't really have cars. They are farming with a machete, maybe a shovel, using their bodies all day long. What I would say is they're less comfortable than us, but they have kind of an ongoing lower level of discomfort, but they aren't experiencing the type of failures in their system that we are experiencing in orthopedics.
And how much of this is due to diet? You mentioned the itises there. How much is diet involved in, being a contributing factor to the pains that we experience?
I think it's really big, and I'm just reading a book right now called Hacking of the American Brain that talks about how we become addicted to sugar and how that's affecting many things, but leading to obesity and diabetes. And so I'm personally gaining more of an appreciation for how much diet is having an effect. There's also a lack of antioxidants in our diet, and antioxidants help to reduce pain. Things like magnesium can help to reduce pain, and there's omega-3s, and there's many things that are now missing from our diet that can help to decrease our awareness of pain and our sensation of pain. So I think it has a big impact, and it's something I haven't really considered in the past, but I'm learning more and more about.
Mm-hmm. Now, Dr. Jim, let's talk about somebody that comes into your office with a pain problem. How do you go about evaluating them?
Well, I start out with some general questions and find out the history, what led up to it. Was it because of a car accident, or was it just kind of gradual? And probably 95% of what we treat just kind of started 2 months ago gradually and has been getting worse ever since. Then I take a look at how they walk. I do some measurements about how strong they are, how the alignment of their joints, how their joints move. I always start with checking the hip strength, and that gives me a clue about the alignment of their pelvis. And I find even people with elbow problems, if you address the pelvis first, then the work we do on the elbow it'll stick, it'll last. Whereas if I've had patients in the past where they just haven't been getting better, or they get better for a day or two, but then it returns. And then when I get around to checking the pelvis, I find it's out of alignment. And when I fix that, then we progress much quicker. So I now do that up front with everybody. And then I go on to check the soft tissue and the joints and the thoracic spine and the ribs and all the joints involved with wherever it is, and then get those to move better and work on the soft tissue in terms of muscles, and then I'm educating the whole way along. So if they have a shoulder problem, oftentimes they have a forward shoulder, which means it's going to be tight in the front of their chest. So I work on loosening up their pec muscle, and I'm talking to them about why that's important and how the shoulder blade position affects how the shoulder works. And if we can get the shoulder blade into a better position, then the alignment's going to be better and they'll have less pain. So I'm looking for the big picture is I'm looking for as many of these faults that I can find, making them as ideal as possible, and then having them experience their new way of moving now that their body is freer.
Now, I've talked to quite a few physical therapists in the month of October here, and they all seem to come back to looking at the pelvis. Why is the pelvis so important in diagnosing these problems?
Good question. I now think of it like, well, one way I've seen it described is it's like a platform with one lever going up and two levers going down. So it's really the center of movement. Now we're designed, we evolved to walk. We've been walking for at least 2 million years, probably longer. And we're very efficient at walking. We're much more efficient than any other animal. And walking is our upper body and our lower body are moving in opposite directions. So as I bring my left foot forward, my right hand is going forward, and my left hand is going backward. So there's there's like a reciprocal motion between the arms and legs, and it centers around the pelvis. I think that has a big impact. The other issue is that when the pelvis is out of alignment, then the sacroiliac joint is stuck. It doesn't have the movement it should have. And when a joint doesn't move well, or when a joint is stuck, it neurologically inhibits the muscles around it. So, for example, I could be working with a person who I test their hip strength, and on the right side, their hip strength is great, and on the left side, their hip strength is weak. Let's say they have a knee problem. So they come in with a knee problem, hip strength on the, and their knee problem is on the left, hip strength is weak on the left. Now, they've been walking, they've been doing everything with both legs, so why would the hip strength be weaker on the left than the right? But it turns out that their pelvis is out of alignment on the left side, their sacroiliac is stuck. I free that up, I get the alignment better, I get the joint to move better, and immediately the strength comes back in that hip. And when the strength comes back, then some of the muscles that were working extra hard can now calm down. Also, they're going to have better alignment in through their knee and foot because now their hip is doing a better job of controlling the alignment of the knee. So I think it's that inhibition of the muscle strength, which then affects the alignment and movement and which muscles we're using, that has a really, which is the cause or which is the reason that you really have to start with the pelvis.
So how do you get back into alignment? You know, when we talk about alignment, we usually think maybe more of a chiropractor, or do you use, is that when you have the hands on and you're using more massage or manual therapy? How do you get that hip back into alignment that's out of alignment?
Yeah, good question. So it's a combination of all those things. So, for example, I'll have them lie on their stomach, and I'll feel that SI joint, that sacroiliac joint on the left side. Oftentimes, there's extra soft tissue. Could be tight muscles. It can be fascia that's developed. So I'll loosen that up with my hands. Then I'll actually push on the sacrum and mobilize the sacrum, the SI joint, by pushing on it. We don't do anything that makes any noise. It's very gentle and just moving it. And then I'll use the leg to mobilize the joint. And I'll move the leg to where the joint starts to get limited or it starts to get stuck. And then I'll ask them to prevent me from moving them further. So they'll contract a muscle. It may be their quad muscle on the front of their thigh. For example, they're on their stomach. I bend their knee. As I bend their knee, I get to a point where I feel it kind of bind up in the sacroiliac joint. So then I'll use my hand to, I'll say, don't let me move you any further. That'll contract the muscle in the front of their thigh, which will then rotate their pelvis and loosen it up. And then I'll go through some other directions. And so basically using their muscles to free up the joints. And these are techniques I've learned through the Institute for Physical Art. Greg and Vicki Johnson think the world of them, and they're techniques that I've learned through them that work really well. And they're very gentle. I never had an adverse reaction, never had a person get worse, never, and the person doesn't really even know that much is happening. There's no noise, there's no sudden impact or anything like that.
Just gradually working through those stuck areas.
Exactly. My new motto is working it works. So working a joint, working an area, working the soft tissue through gentle techniques of massage, also resisted movement, frees it up and gets it to move better.
So what should people know about working with a medical doctor when it comes to orthopedic problems?
Yeah, another really good question. I find so one, working with an orthopedic doctor, what you have to keep in mind is that they're going to really be focused on finding the damaged tissue, the damaged area, whether it's a disc herniation or knee arthritis or meniscal tear, or they're going to want to come up with one word or a couple words that describes where the damage is. And they'll use x-rays and MRIs to do that. The problem is that it turns out a lot of people who don't have any pain also have the same damage when they look at an x-ray or an MRI. And in fact, say it's knee arthritis and a person developed pain a month ago. Well, if you did the x-ray 6 months ago, they probably had the same knee arthritis, but they didn't have pain. So you have to really, I tell people to take everything with a grain of salt. It could be that the pain is coming from the knee arthritis, but it could also be that it's from sore muscles. It could be that it's coming from the way the kneecap is aligned. It could be from the iliotibial band. It can be from a lot of different areas. It can also be that if you take stress off of that damaged tissue, that damaged area, and restore that joint motion and that joint alignment and free up the motion and just get it closer to what we're designed to have, then the pain will go away. Even though the damage didn't go away, the pain can go away. So that's what I would always be asking, could I try physical therapy first? If the doctor is saying, you have a torn rotator cuff, you're going to need surgery, I would say, can I try physical therapy first? A person may be able to avoid surgery, maybe not. They may end up needing surgery. So if they can avoid surgery, that's great. If they end up needing surgery, they're going to do better in that surgery having done physical therapy first. So they're going to have a more successful surgery. So worst case scenario, they have a more successful surgery. Best case scenario, they're able to avoid it.
Now, the body heals itself and it regenerates, and at the cellular level, multiple times throughout your life. Given the correct movement and freeing up biomechanically the movement of the body, can an injury such as a torn meniscus heal itself?
No. But it turns out you don't need to, or oftentimes you don't need to. They also so that's the physical therapy side of it. Let's look at the surgery side of it for a second. A couple of years ago in Scandinavia, they did a study where they did fake meniscal surgery, fake arthroscopic surgery. They had 200 people. Half of them had regular surgery. Half of them had fake surgery. They just made a couple incisions and then had them follow up with a different doctor who didn't know who had had the real surgery and who had had the fake surgery. And it turned out each group did equally well. Each group had improvement from the surgery, whether it was real or fake. So in that particular case, with the meniscal injury, there's a placebo aspect to it. It turns out there's a placebo aspect to surgery. And because of that, doctors are are much more reluctant to do meniscal surgery than they were 3 or 4 years ago. I'm seeing a lot less of it. I'm seeing much more frequent referral to physical therapy. And if we can, again, restore good alignment, then we can get that area to calm down and the pain goes away.
That is extremely powerful. Great for physical therapists that doctors are, sending more people to you for help rather than surgery. But that just shows you the power of the mind and the placebo. If you think you're getting better, then you are getting better. So let's talk about some of the misconceptions surrounding physical therapy. What misconceptions do people have about what physical therapists do?
I think one is that we don't operate autonomously and that we can't diagnose problems. That we have to work under the guidance of a doctor. When I get a prescription, I look at what the doctor thinks the problem is, but I make my own assessment of it. And even if and I think differently. So if a doctor says you have a person has a meniscal tear, yeah, I'm not going to argue with that. They definitely have a meniscal tear. But now I'm looking at hip strength and ankle alignment and ankle range. Do they have flat feet? Is their leg rolling in? What are the mechanical aspects of how they move that we can change that's going to take stress off of that area? And that I don't look for a doctor from. I'm making those assessments myself.
So they're really, seeing the problem, but you're looking at the underlying cause of the problem.
Well, yeah, I'll just add that they may be seeing the problem. They are seeing a problem, but we don't know for certain whether that meniscal tear is actually what's causing their pain, or whether that disc herniation is what's actually causing the pain. So we always have to keep that in the back of our head that, they have that showing up on their MRI and X-ray, which may or may not be what's causing the problem. So
the patient might come in with a complaint of a sore knee, and to them, that is their problem, is that they have a sore knee, but the underlying issue is, a biomechanical movement that they're doing, or, some weakness in some areas of their body.
Exactly. And even if they have a meniscal tear, the biomechanical issue is what led to the tear in the first place. If we're not moving correctly, we're going to wear things out quicker and in an uneven way, and that will thin the meniscus, for example, and make us vulnerable to a tear. So it's a contributing factor to what led to the problem in the first place.
Now, Dr. Jim, you have been practicing physical therapy for over 20 years. During that time, tell me about a difficult case that you may have had that turned out well, and what was the ultimate problem and outcome for your patient? Yeah,
let me. A couple come to mind. One is kind of quick. Person who had fallen and broken her hip, and she had a hip replacement. And then 6 months later, she fell again and broke the femur, where the hip replacement goes into the bone. It's the injury that happened to John Kerry. And the woman was on crutches. She was non-weight bearing for 3 months. The doctor, said you can't put any weight on her for 3 months, so she's on crutches. When she came in, she was walking, but that hip was very weak because she hadn't used it. So I went through my evaluation. I checked the sacroiliac joint. It was stuck, so I freed it up. And in that one appointment, that hip became stronger than the other hip. And she happened to be a doctor, and I found it hard to believe that had happened, and she found it hard to believe that had happened. So it really, so the idea of disuse leads to muscle weakness and atrophy, in her case, didn't apply. It was the stuck SI joint was inhibiting the muscles around the hip and making it weaker. Mm-hmm. So that's one. I worked with a gentleman who had 3 back surgeries. The first one in the late 50s, and the third one put him in bed for 3 months. And we went through a very we addressed the soft tissue issues and alignment. And then we went through looking at his lifestyle. Now, he liked to sit on a couch, and he had trouble getting up from the couch. So we worked on how he sat there, using pillows to sit up straight, worked on his mechanics of how he would lift things. And we had some situations where he had some pain when he was lifting things, but we continued to work on his technique. And by the end, he was lifting 2 grandchildren at one time. He was washing his car by hand. He was cleaning a deck by hand, fully functional, and had no pain. One other comes to mind. It was a person who had a full rotator cuff tear, as well as partial tears of a couple other muscles and some damage in the shoulder joint. And by starting out with gradual strengthening and building up, he was able to be fully functional, lift his arm, no pain, and avoid rotator cuff repair.
And all these cases, it really, just enhances the overall lifestyle of that person and gets them back to normal, being able to move freely without pain, which is, exactly what it is that you do in physical therapy. Now, tell me, Dr. Jim, what got you started in the physical therapy industry many years ago?
Yeah, my undergrad degree was in business, and I was a sales rep for 10 years. I wasn't very good at it, so I got to a point where I realized I had to do something different. And I loved to exercise. I found I knew I was better at helping people than selling people. So all I knew was physical therapy. I knew that all I knew was the 2 words. I didn't know what they did. But as I looked into it, it seemed like a good match. And now I know it's the perfect match for me. My dad was a mechanical engineer. My mother was a teacher. So it's a really good combination of thinking mechanically, but dealing with people and educating and listening and working with people in a collaborative way. So I love it. And I'm very fortunate to have found the perfect career for me.
Definitely. Now, any last thoughts, maybe some either secrets to success or some steps that people can take to avoid getting injuries?
Yeah, I think that what people tend to think is, what did I do to make myself have this problem? And I'd like people to start thinking about, what didn't I do? Maybe the problem didn't come about because of what I did. Maybe the problem came about because, in general, over the past 5 or 10 years or whatever, over the long period of time, I haven't been moving enough, and it's made me vulnerable to this injury. I think also we as an American society need to get a little more comfortable with discomfort. Pain is okay. It's not the end of the world. We can control it, and we don't have to jump to medication by doing some simple things like ice and resting it if it's really inflamed, and gradually moving through it and getting some assistance with the process. We can overcome it, and we can return to full life without pain, and we don't have to rely on opiates or anti-inflammatories or things like that.
So it's all about moving more often and keeping the body working through that full range of motion. Well, exactly. Dr. Jim Ruetenik, thank you for being my guest on Business Authority Radio today. If people want to get in touch with you, what is the best way for them to contact you?
So our phone number for our clinic, and it's Soma Physical Therapy and Rehab. Soma is S-O-M as in Mary A. And the phone number is 781-400-1236. 781-400-1236. We're online. If you look up Soma, we're in Needham, Massachusetts. Yeah.
So, and the website is Soma PT and Rehab.com. Is that correct?
That's correct. Yep.
Excellent. Well, I encourage anybody that's in the Needham, Massachusetts area to contact Dr. Jim Ruetenik if they have any biomechanical issues or pain problems. And thank you again for being my guest and discussing all these things about physical therapy with me today.
Thank you very much, Neil. It's been a pleasure.
And to our listening audience, if you like what you hear, hit that like button, share, and we'll see you next time on the show.
You've been listening to Business Authority Radio with Neil Howe and Greg Williams. To learn more about the resources mentioned in today's show or to listen to past episodes, visit businessauthorityradio.com.